All right, well, welcome to this pharmacology drug class review on the category of antilipemics or lipid-lowering drug therapy that target triglycerides. Specifically, we're going to be focusing our attention on omega-3 fatty acids, also known or referred to as fish oil. Now, in this session, I'm going to explain why omega-3 fatty acids matter, make it easy to understand, clinically relevant, especially in the context of patients with hypertriglyceridemia. All right, guys, I'm Dr. Busti. Thank you for joining me on This Is Why, a show dedicated to helping us as healthcare professionals understand the why behind the pharmacology and the drugs that we all use every day. Because when we understand the why, the how becomes easier and that mechanism starts to make sense. In this class, we'll see that side effects and contraindications and sometimes even our monitoring and counseling points correlate back. All right, so as with all of my drug class reviews, we cover that core content, things that you just have to know. Sometimes you have to memorize it, depending on where you are in your training and clinical practice. Number one is, what are our agents? Number two, what is the common indication and or uses and the net benefit to this class of drugs? Those are big picture, like must-know items. And then we start diving a little deeper into mechanisms. This one's a little bit more complicated, a little bit fuzzy, less known. Okay, but we'll do our best. I'll try to make sense of it as much as I can, and then we'll translate into some of the clinical application and knowledge pearls that, again, will benefit you in real-world clinical practice. So with that, let's start off with our agents, and we have really two. When I'm talking about from a prescription standpoint, I'm not going to be focusing my attention on this topic review as it relates to over-the-counter available fish oil or omega-3 fatty acid supplements. I'm really going to be focusing on the ones that were more prescription based. So we have the omega-3 ethyl esters of EPA and DHA, which are represented two of the three most common omega-3 fatty acids. And then there's Icosapent ethyl, which is only the EPA version. Okay, it does not contain DHA. Our bodies need and use different fatty acids for different reasons, but in the context of lipids and cardiovascular disease, you're going to see a little bit of the lean towards EPA. All right, now let's move to the the indications and common uses. I'm jumping ahead of myself. All right, and so that's easy, right? The thing that makes sense is that it's for triglycerides. That's what I started out talking about, but let's break that down a little bit further. Triglycerides typically equal to or greater than 500 milligrams per deciliter. For sure over 1,000, right? We want to give this consideration. Now, we do have other options available, right? Fibrates that can be also used in similar fashion, but that's where this indication primarily resides. Now, Icosapent ethyl has also indications for cardiovascular risk reduction in patients with hypertriglyceridemia and patients who are on max statin therapy with established cardiovascular disease or type 2 diabetes with two risk factors, okay? So that detail is part of the way that the drugs were studied and got approved. So it's just a couple nuances, but wanted to make sure that you understood those indications and uses. Now, moving on to our net benefit of the drug class. I think it's pretty straightforward. Our goal is to target triglycerides, and in that case, we can get up to 40% reduction from the baseline. But interestingly, these drugs have also been associated with a reduction in ApoB 100 by as much as maybe 10%. So, like, what's that about? Remember, every lipoprotein, or not everything but HDL, has an ApoB in it, 100, okay? That protein is identifier for particle number. So when we measure lipid profiles in most cases, when we're talking about them like triglycerides, it was 500 milligrams per deciliter. That is a mass per unit volume. That's a concentration. ApoB tells us how many particles are inside that volume, okay? And so when you can reduce the total number of particles, that's good. So that's a benefit, okay? Now, Icosapent, being that it's only EPA, right? It is associated with some reduction in ischemic cardiovascular events which has not been seen when you use the combination. So that's where the thought with DHA is that, yeah, we need to focus on the EPA because that's where the evidence seems to lie. And I'll bring this back up again a little bit later in the topic review, but I wanted to kind of point out that thing as it relates to cardiovascular, specifically related disease. All right, now moving on to, let's go into the pharmacology where we'll start diving a little bit deeper. I will admit there's some unknowns. There are suggestions and there's different theories and there's different hypotheses or some different types of data that have been looked at for various mechanisms. And I think it's multifactorial, to be honest with you, at the end of the day. There's nothing wrong with that, okay? But just recognize it's not as clean like, HMG-CoA reductase inhibitors or statins or ACL inhibitor like bempedoic acid. We know the mechanism, okay? So omega-3 fatty acids, let's talk about what they are, what they look like, so we can make sure, because there's omega-6 fatty acids that are not beneficial to us in general, okay? Too high concentrations. So omega-3 fatty acids are dietary fats that are referred to polyunsaturated fatty acids, PUFA, PUFA, right? So they're unsaturated due to the presence of more double bonds. And what that does is it makes their structure less rigid or more flexible, okay? And again, the three main fatty acids that we're talking about that are omega-3 fatty acids include alpha linoleic acid, ALA, and then there's DHA and EPA, which we've been talking about predominantly, okay? Again, EPA being the Icosapent ethyl. That's the main one. But what do they look like when we start breaking this down? Not that you're going to, have to be tested on this, but I just kind of wanted to put the context in there for you, okay? It really has to do with the double bonds. So over here are omega-3 fatty acids, and over here is our omega-6 fatty acid, predominantly what is known as arachidonic acid, okay? This becomes very important when we start talking about inflammation. It also becomes relevant in the context of the risk of bleeding that's been discussed with omega-3 fatty acids. But when we say omega-3, it has to do with where the double bonds start. Remember, they're not saturated, they're more unsaturated because of these double bonds. And so you see it goes 1, 2, and at the third. 1, 2, and at the third. 1, 2, and at the third. Whereas omega-6 is 1, 2, 3, 4, 5, and then the sixth one is where the double bond starts. It just has to do with the way that the body likes to handle these molecules once they're placed in the body in various locations, right? Now, this table that I provided you, again, depending on if you've watched other lipid-lowering lectures or topic reviews that I've done, you've seen this. It is complicated, it's busy, it's got a lot of things. You might not be able to even see it or read it on the screen if you're watching this on video. If you're joining us on the podcast, I'll walk you through it here quickly, but these tables and images are available to you at thisiswhy.health for free, okay? There's other things that you can get there, other benefits for joining and following and being a part of the community. If you want to learn and understand things, why, that's there for you. But feel free to download it, share it, put it on social media. It's up to you, right? If you teach, use it. If you feel like it's beneficial. That's why I developed it. Now, this table is organized by the target of the lipid lipoprotein. So you see that we have the LDL that's targeted by statins. We have LDL targeted by non-statins. Triglycerides, where we have our fibrates, MTP inhibitor, and then we have our omega-3 fatty acids. So we're right here. And then, of course, the miscellaneous agent, niacin, which kind of hits a lot of things, not just triglycerides, but also HDL, has a little bit of effect on LDL. It's kind of again, miscellaneous, right? So we're in the omega-3 fatty acids, and I tried to put the classic agent in the second column. It's not the all agents listed for each drug class. It's not what it's meant to be. I talk about the mechanism, and you're going to see that DGAT is one of those, right? Diacylglycerol acetyl transferase. is the enzyme that is likely to be inhibited by the omega-3 fatty acids in the production and synthesis of triglyceride-rich VLDL. And that's what gives us our roughly 40% reduction in the triglycerides, which is that fourth column, that's the target lipid. What is the main thing that we're trying to use with this drug class? So I've been repetitive about that, but there's also an impact on other lipid effects, what happens to LDL and what happens to ApoB. Remember, a reduction in ApoB is a reduction in the LDL particle count predominantly, okay? Now, mechanism. I mentioned DGAT here, right? That is probably the main one that we know most about and is likely the thing that if you were asked on a board exam or something like that, I have taken, you know, being a nurse, pharmacist, physician, done this for years, I have never seen the mechanism of action omega-3 fatty acids detailed out like this except on my clinical lipidology boards. Outside of that, I've never seen it because it's not clear. It's you know, there's some debate about it, and depending on what paper you read, you see all these other effects. In fact, it even functions like ezetimibe, right? There's evidence in animal data that it can suppress the upregulation of Niemann-Pick C1-like peptide, which is really cholesterol absorption in the intestine, right? So, you know, it's multifactorial is what I would suggest, right? There's also involvement of PPAR alpha. There's peroxisomal beta oxidation and changes in the hepatic rate of that. Right? All these things, in the totality of them, right, seem to lower the overall output of triglyceride-rich VLDL particles. But DGAT is probably one of the more commonly cited ones. When we start thinking about pharmacokinetics and pharmacodynamics, icosapent absorption really is about it's a deesterified EPA, okay, which is the active metabolite, more effectively absorbed in the small intestine. Where you compare EPA DHA combo versus EPA, remember again, it's EPA-Only theoretically or hypothetically lacks the presence of the DHA in its administration. It doesn't mean you start getting it from the diet. But the thought is that maybe that was a small contributor. If you saw on the previous slide a plus or minus LDL, there's some suggestion that these drugs can raise the LDL. In part, that is due to changes in the buoyancy and diameter, because as you reduce triglycerides, LDL concentration should go up, because you shift LDL particles from a smaller, dense LDL particle when high triglycerides are present to a larger, more buoyant particle when the triglycerides are lowered. And by shifting the size of the LDL, you're actually improving the quality and making it theoretically less atherogenic, because the more dense and small the LDL particle, the more likely it is to penetrate the endovascular lining and cause atherosclerotic disease, okay? At any rate, all right, now we're going to kind of migrate over to that clinical application and some of the clinical pearls that apply and build on some of the things I was just talking about. And the first is the place in therapy. We talked about its primary role in triglycerides, especially with the triglycerides of 500 or more. And then with icosapent ethyl, because of its evidence, right? Remember, it's EPA-only, no DHA. May have to confer that additional benefit in cardiovascular disease. When you look at other studies like AIM-HIGH, ACCORD, HPS2, THRIVE, those studies didn't show any added benefit or value when trying to target additional triglycerides and HDL effects with omega-3 fatty acids on top of patients already on statins to try to get additional control, right? So the idea was the statin is getting the LDL under really good control. Should we maximize these other variables? Well, remember, there's only so much benefit in cardiovascular disease prevention that you can do. And so as statins already reduce that. So how much more left? it is hard to prove. So I feel like some EPA DHA maybe is disadvantaged, but these are big studies, right? They're relevant. So when you look at this pattern of association in the data, that points to a story or basically the outcome. And that's why this is kind of, DHA is kind of fallen out in this discussion and people have focused more on the EPA side. But remember, our bodies use fatty acids in different locations, different organs differently. And so there is a point of balance there. So I don't want to dismiss that DHA is no value. That's not true. Okay. Now, this table is just a comparison of the dosage formulations by brand name, generic name, indications, how much EPA and DHA is available in each dose, okay? Because that's the omega-3 fatty acid component. And this is the problem right here in this column, is the amount of omega-3 fatty acids present in over-the-counter, right, non-prescription formulations. A lot of times those products are filled with other things, vitamin E and cholesterol and all this stuff. Whereas prescription drugs are obviously clean, pure, through manufacturing processes. They have to be tested and validated for only having this. And so you can see how much EPA you're getting in Icosapent, Ethyl, how much EPA DHA total. Well, you're getting close to that gram, right, basically. And so when you think about lowering triglycerides, I mean, studies have been done all the way up, like I've seen 6,000 and 8,000 milligrams a day, not necessarily of these, but of fish oil, omega-3 fatty acids, that patients have tolerated it. But you're probably gonna need that 2,000 milligrams window before you really start seeing legitimate triglyceride lowering effects. Obviously side effects like GI stuff, dyspepsia, dysgeusia, like fishy burps, stuff like that. Those are issues that make it less pleasant and can sometimes affect compliance. But I try to put that table together for you again. You can download that at thisiswhy.health. Other things to be considerate of is the risk of AFib that's kind of circulated. It occurs in the first 3 months of therapy. In patients with risk factors with AFib, like heart failure, they already have dilated atrium, the proximal portion of the pulmonary artery is already stretched. I mean, you may not know that unless you have an echo. Patients have already had intermittent cardiac dysrhythmias. Sometimes this can be a risk. The next thing is bleeding. So omega-3 fatty acids have been thought to impair platelet function. So they don't let them, basically adhere. And there may be also some impact on the clotting factors. Again, may. The evidence on this is very mixed, but where does it come from? Well, when you look at cell membranes, remember that's a lipid bilayer. And so what makes up that lipid? Well, a lot of it is of omega-3 fatty acids and omega-6 fatty acids. And the ratio of that influences in part the downstream effect. So when omega-6 fatty acids get released, right, arachidonic acid, it's going to get metabolized through cyclooxygenase and form prostaglandins. And that pathway will feed and turn on pro-inflammatory cytokines, number one. Number two, it will also facilitate the production of thromboxane A2, which is going to activate platelets, turn them on. And if you activate a platelet, then you will facilitate platelet aggregation, okay? But what is omega-3 fatty acid doing? Well, if you have more of a omega-3 ratio inside the cell membrane, so your diet or what you consume, you'll compete with the omega-6 fatty acid. And that's what's happening here. So you have EPA, DHA, and if the two of them are there, or maybe there's more omega-3 fatty acids, well, you're going to preferentially go down that pathway that shunts and forms more prostaglandins and has antiplatelet properties and antiplatelet effects. One of the other effect is that on platelet activating factor. And so you could increase the risk of bleeding time, and you may impact the platelets' sort of release of other chemical mediators that would facilitate activation and aggregation. And so that altogether, the totality of that effect would be concerned of risk of bleeding. And there are surgeons that I know of and I've seen that make patients stop their fish oil or omega-3 fatty acids a week or so before surgery to minimize and reduce the risk of bleeding, because you don't want bleeding in invasive procedures. But when you look at the actual evidence and the totality of that evidence, it is extremely rare. Very, very little supporting data that actually translates into clinical outcomes that are negative for the patient or even the providers managing them. But still, because of the risk, and there's the theoretical concern, you'll see that providers will have patients stop their omega-3 fatty acids or fish oil as a result of that during that time. Now, allergies, fish allergies. I mean, is it the same sort of thing? Patients with a known hypersensitivity of fish or shellfish, yes, maybe use some caution, but it's not considered an absolute contraindication. What about hypervitaminosis? What is that? Well, that goes back to what I was talking about before, especially with the over-the-counter products that get filled with things. And when you look at the label on the front, it says 1,000 milligrams of fish oil. That's not 1,000 milligrams of omega-3 fatty acids. You have to turn the bottle around and actually look and see how much EPA DHA is in each capsule, and it'll blow your mind. Some of them are so small in amounts that the rest of the stuff you're getting is stuff like this, vitamin A and D. Well, what's the problem with vitamin A and D at high concentrations? Well, those are fat-soluble vitamins that we're not just going to easily get rid of, okay? So they can become toxic, okay? And this is where I want to pause for a moment and just introduce a quick, fast fact about this. Because it's not just about the vitamins, guys. It's also about other impurities, one that includes mercury, okay? And there's a lot of movement and a lot of use of omega-3 fatty acids during pregnancy for brain development, and it's true, there's a benefit to that. I'm not minimizing that. I like omega-3 fatty acids. I think that they have a lot of value, but the source of it could be a concern, because you could be consuming things when you use products that don't go through third-party testing or follow good manufacturing processes and then have third-party purity testing. You run the risk of being exposed to these fillers that can be toxic to patients. Okay, anyway, I want to jump back in. I just wanted to make sure that we give that some consideration. Now, moving on to the last kind of part is like, what are we doing to monitor these patients? Well, I mean, obviously we're treating triglycerides, we're treating the lipids. It could have an effect on LDL, ApoB. Ideally, you want to check those at the baseline and then periodically thereafter, usually around 3 months. And then once they're stabilized, tolerating it, they're on standard doses, then, you know, every 6 to 12 months is fine. What about the coags? Should you check PT-INR? I mean, if that's the only thing they're on, no. But if they are at higher risk for bleeds or there's concern, maybe. I've never seen PT-INR go up significantly with omega-3 fatty acid supplementation. Just haven't seen it. I'm not saying it doesn't exist. I've never seen it clinically myself, right? Liver enzymes, again, I don't see that. People get concerned because of statins and other. I mean, but think about these. These patients many times are on other drugs that can cause that. But I've not seen that it causes liver damage. Okay. All right. So pulling this together, omega-3 fatty acids, we have the combination DHA, EPA, and then we have Icosapent ethyl, which is only that EPA, has more indications, more evidence in cardiovascular risk reduction. Mechanism is, it's fuzzy, right? But there's an overall net output reduction in VLDL that's triglyceride rich, and then also increasing the catabolism of the VLDL. Side effects, fairly well tolerated, bad taste, maybe a little dyspepsia, dysgeusia, like, I don't like the smell of that. Maybe a small risk of bruising, bleeding, but remember, again, that's very low. It's gonna reduce those triglycerides. You're gonna get about 40%, but you gotta get up to that 2 grams of EPA DHA a day in order for that to work. Drug interactions, pretty low. Tolerability, pretty high. Benefit, somewhat questionable. Okay, guys? So I hope that you found that helpful in the context of antilipemics, lipid-lowering drugs, understanding where this drug class fits in combination with other drugs or the lack thereof. So thank you for joining me. Thank you for being a part of this. Thank you for investing in what you do. I know it's a lot to absorb. I know that investment in understanding why takes effort, but I appreciate you and we learn from each other. And so please, if you haven't done so, subscribe to the channel, give us a like. Again, really appreciate that. Thank you for being here. I'm Dr. Busti, and never stop learning the why, because it makes how to manage patients easier when we understand why we're doing what we're doing. Take care.